Welcome back to the deep dive. Today we're really digging into something critical in equine medicine. We're tackling blood and plasma transfusion reactions in horses. Fascinating stuff, but also pretty complex. We've got your stack of sources here, and our mission is to pull apart the key info. We want to understand what happens when these life-saving procedures, well, go wrong and why. By the end of this, you should feel much more clued in on this vital area.
It really is vital, yeah. Transfusions, they save lives. Think severe hemorrhage, anemia, clotting problems, even failure of passive transfer in foals. Huge benefits. But, and this is the crucial part, they come with risks. Risks that range from, pretty mild to potentially fatal. What's so compelling is just how varied these reactions can be. It's not simple.
Okay, let's start right there. Transfusion reaction sounds simple, maybe like an allergy, but your sources suggest it's much more complicated than that. What exactly is a transfusion reaction?
Right. So a transfusion reaction, or TR, is basically any negative clinical thing that happens because a horse received blood or blood components, BPs. And it's not just about the horse reacting to foreign blood. The sources point out reactions can happen from using, let's say, non-ideal products, maybe blood with extra plasma it doesn't need, or even just problems with how it was collected, stored, handled, or given. All potential triggers.
So it's not just one thing, a whole range of possibilities.
Exactly. We generally split TRs into two big camps.
Yeah.
Immune-mediated, where the horse's immune system gets involved, and non-immune-mediated. Some involve hemolysis, red blood cell breakdown, some don't.
Yeah.
And timing.
Yeah.
It's all over the place. Some hit immediately, others can be delayed hours, even days. Plus, there's the risk of transmitting infections. So, yeah, it raises the big question. What causes these different types?
Okay, the immune system part sounds really interesting. Your sources really zero in on this. How does the horse's own body end up fighting the transfusion?
Yeah, this is key. Blood products from another horse have these things called alloantigens on their cells. Think of them like little flags the recipient's immune system might see as foreign, as not self. And recognizing those flags can trigger an immune reaction. But here's the fascinating part, and it often surprises people. Unlike us, horses generally don't have preformed, naturally occurring antibodies against the major blood groups. There are some minor exceptions, like antibodies sometimes, but it's not the norm. What this means practically, and it's super important, is that hemolytic reactions, the severe breakdown of red cells, are actually uncommon during a horse's very first transfusion.
So the first time might be okay.
Often, yes, but, and it's a big but, the horse's body learns fast. Alone bodies, the ones that fight those foreign red cell antigens, they develop within about 3 to 10 days after that first exposure. So while the first one might seem fine, you absolutely have to be cautious with any later transfusions.
Ah, okay. So it's like the first one is a free pass, maybe, but the second one is where the danger really lies because the immune system is now primed. It's learned.
Precisely. That prior sensitization is the #1 cause of really significant immune reactions. The immune system remembers.
How does that sensitization usually happen then?
Well, the most obvious way is a previous transfusion. If the horse got blood before, it likely built antibodies.
Yeah.
Pregnancy is another major route. A mare can get sensitized to her foal's red blood cells if the foal inherited a different blood type from the dad, the stallion. That's actually the whole basis for neonatal isoerythrolysis, or NI. The mare's antibodies go into the colostrum, the first milk, and attack the foal's red cells. And though it's pretty rare, contaminated needles or equipment could theoretically do it too.
Makes sense. So what kind of immune reactions should you be watching for? What are the common signs?
They really vary. You can get mild to moderate signs. Think fever, maybe a rise of over 1 degree Celsius during the transfusion, restlessness, a faster heart rate, faster breathing. Those are often the first clues. You might also see hives, urticaria we call it, itching, especially face and neck, muscle tremors, just looking generally unwell, maybe even colic signs.
Okay, those are the milder ones. What about the really serious life-threatening reactions?
Right, those are the scary ones. Acute hemolysis is a big one, rapid red blood cell destruction. You'd see hemoglobinemia, that's red-tinged plasma, and hemoglobinuria, which is dark reddish urine. That can quickly lead to shock, kidney failure, DIC, which is a massive clotting problem. Bad news. Then there's anaphylaxis. It's rare, thankfully, but incredibly severe. You're talking collapse, severe low blood pressure, sweating buckets, really bad diarrhea, major trouble breathing.
And you mentioned specific organs?
Yes, in horses, the lungs and the gut are often considered the shock organs. So sudden, severe colic and diarrhea can actually be early signs of anaphylaxis. Interestingly, fever is often absent in anaphylaxis, which can be misleading. You can also see heart rhythm issues, unconsciousness, cardiac arrest, even death.
Wow. Any other immune types?
Yeah, there are delayed immune reactions too. These show up maybe days later. You'd see a gradual drop in the PCV, the packed cell volume, maybe a lingering fever, poor appetite, jaundice. The transfused cells just don't last long.
Okay, so that covers the immune side. But you said not all reactions involve the immune system fighting back. What about the non-immune ones?
Exactly. These are usually related to other factors, like the physical volume of the fluid given, or the blood components degrading during storage, or maybe bacterial contamination. Even the anticoagulant used to stop the blood clotting can cause issues.
Like what kinds of issues?
Well, circulatory volume overload is one, giving too much fluid too fast, especially if the horse already has heart problems or wasn't dehydrated to begin with. You can also get hypocalcemia, low calcium. Often that's from citrate toxicity, the anticoagulant binding up calcium. Too much anticoagulant can also, paradoxically, cause clotting problems, a coagulopathy.
And infections.
Yes, that's a serious non-immune risk. Transmitting blood-borne diseases. We know things like Thieler's disease virus causes serum hepatitis, and equine infectious anemia virus can be passed through plasma. Whole blood can transmit parasites like Babesia or bacteria like Anaplasma.
Any other?
Sure. Things like hemosiderosis, which is iron overload, or hemoglobinemia, free hemoglobin floating around. Hyperkalemia, hypotassium, can happen if you transfuse red cells that have already broken down, releasing potassium. Oh, and a specific point from the source is liver failure is a known complication in foals getting big transfusions, say over 4 liters. There's a drug, deferoxamine, that can help reduce that risk. And finally, even things like pyrogens, fever-causing substances, or inflammatory molecules can build up in stored blood and cause a reaction.
That is a lot of potential ways things can go wrong. So how often does this actually happen? What do the numbers say? And who's most likely to react?
We do have some figures. For plasma, foals under a week old seem most vulnerable, with a reaction rate around 9.7%. That's quite high. In older horses and adults getting plasma, it's lower, maybe under 2% for commercial products, but it can jump to 10% if the plasma is prepared in-house, not commercially. For whole blood transfusions in adults, the reported rate is around 16%.
So foals under 7 days, definitely a higher risk group for plasma.
Yes, the data suggests rates somewhere between 6 and 10% in that age group.
And looking back at a horse's history, are there red flags that might signal a higher risk before you even start?
Absolutely. History is key. Number one is obviously a previous transfusion. That sensitization risk we talked about. Also, if you know the blood product itself was old, maybe damaged, hemolyzed, that increases risk. And then there's technique. Improper sterile procedures during collection or giving the blood, or improper storage or handling of the blood, the plasma, or even the tubing and catheters, all big risk factors. Genetics play a role too, the sources mentioned. Differences in blood types, obviously, but also white blood cell antigens, platelet antigens, even protein variations contribute.
Okay, so if you're performing a deep dive on reactions, knowing the signs is absolutely critical. You're there, you're monitoring the horse during or after the transfusion. What exactly are you looking for?
Constant vigilance is the name of the game. The signs vary so much depending on the cause. You need close clinical observation, watching vital signs, sure, heart rate, breathing, temperature, but also mucous membrane color, their overall attitude, any subtle changes.
Can we break it down? What are the signs for different types or severities? Like what's a mild warning versus a stop everything now sign?
Yeah, let's categorize. For immune-mediated reactions, the early, maybe mild to moderate signs often include that fever we mentioned, like a 1 degree Celsius jump, restlessness, the heart rate climbing, breathing faster. Then you might see the skin reactions, hives, itching, especially face and neck, muscle tremors, maybe mild colic signs.
Okay, then what about the severe immune signs?
That's when you hit the emergency buttons. Acute hemolysis.
Yeah.
You see that red plasma, the dark urine. It's a massive red flag for red cell destruction. It can quickly progress to shock, kidney failure, DIC. Very serious. Anaphylaxis, collapse, plummeting blood pressure, intense sweating, severe diarrhea, gasping for breath. Remember those shock organs, gut and lungs?
And no fever with anaphylaxis, you said.
Often, yeah. Which can throw you off if you're just looking for fever.
And the non-immune signs.
If it's contamination, you'll likely see fever, fast heart rate, fast breathing, similar to some immune signs, actually. If it's volume overload, look for high blood pressure, those big, bulging jugular veins, maybe fluid sounds in the lungs, heart issues, difficulty breathing. And if it's hypocalcemia from the citrate, you might see weird heart rhythms, colic, muscle twitching, maybe jaw clenching, or that weird diaphragm flutter called thumps.
Okay, so you suspect a reaction based on these signs. What are the next steps diagnostically? How do you confirm it and figure out the cause?
Well, that clinical observation is ongoing. That's your first diagnostic tool, really. Then labs are crucial. You want to check a PCV and total protein post-transfusion. Did it go up as expected? Or is it dropping fast? Just looking at the plasma or serum color and the urine color tells you immediately if there's hemolysis, that's free hemoglobin. A full CBC biochemistry panel, urinalysis gives more detail. You look for anemia, high bilirubin, signs of kidney or liver stress. Finding specific damaged red cells, sterocytes, on a blood smear points strongly towards immune-mediated hemolysis.
What about cross-matching? How important is that?
Hugely important. Now, as we said, that first transfusion might sometimes be done without one in a true emergency because of the low risk of pre-existing antibodies. But cross-matching is highly recommended for all subsequent transfusions and really whenever possible even for the first. It dramatically cuts the risk of hemolytic reactions. It's not foolproof, not 100% sensitive, but it's a critical safety step.
And blood typing.
Also very helpful. Knowing the recipients' and donors' blood types helps select compatible donors, especially trying to find donors negative for those AA and K antigens, which are big troublemakers for sensitization.
Any other tests?
Sure. If you suspect infection, you'd culture the blood product itself or the recipient's blood. If you suspect volume overload, you might measure blood pressure or central venous pressure.
Right. So the worst happens, a reaction occurs. What's the immediate game plan? What's the treatment protocol?
Okay, number one, absolute priority, whether it's blood or plasma. Stop the transfusion immediately. Full stop. Second, keep that IV access. Don't pull the catheter. Keep it open and flush it with standard crystalloid fluids like saline.
Then what?
Then it's supportive care tailored to the signs. Aggressive 5E fluids are often needed to keep blood pressure up, maintain circulation, and flush the kidneys, especially if there's hemolysis. Sometimes, for severe shock, you might use hypertonic saline or colloids. Anti-inflammatories are key. Corticosteroids, like dexamethasone or prednisolone sodium succinate, given IV to calm the immune system. And NSAIDs like flunixin for fever and inflammation.
What about for the really severe anaphylactic reactions?
That's where epinephrine comes in. For severe anaphylaxis or circulatory collapse, given IM or very slowly IV. For milder allergic signs like hives, antihistamines like diphenhydramine can help to watch for some horses getting agitated on them. Bronchodilators if they're having significant trouble breathing. If it looks like volume overload causing breathing issues, diuretics like furosemide, maybe intranasal oxygen. If sepsis is suspected, obviously appropriate antibiotics. And that drug deferoxamine we mentioned, if iron overload is a concern, particularly in foals. And throughout all this, constant monitoring. Vitals every 5 minutes initially, then maybe every 15. Keep the horse quiet to reduce the risk of collapse if their blood pressure is low.
Prevention is always the goal, isn't it?
Yeah.
So what are the best ways to minimize the chances of these reactions happening in the first place?
Absolutely. Prevention is key. And the biggest preventative step is cross-matching. Perform major and minor cross-matches before blood transfusions, period. Especially for any horse that's had one before. It massively reduces risk.
Okay, cross-matching first. What else?
Donor selection. If you can, use donors known to be negative for those highly immunogenic AA and Q antigens. For mares you intend to breed, try to avoid donors that could sensitize her to blood types her future foals might have helped prevent NI down the line. And just generally choose healthy donors, ideally one screened for diseases with no history of reactions themselves.
How about the transfusion process itself?
The rate of infusion matters. Start really slow, like 0.1 LML per kilo per hour for the first 15 minutes. Watch closely. If everything looks good, you can gradually increase the rate, but generally don't go faster than 10 to 20 millimol per kilo per hour pre-medication. Sometimes. It's not routine for every horse. But if a horse have a history of reactions or known allergies, pre-treating with antihistamines or maybe corticosteroids before starting might be considered. Never mix them in the bag, though.
And the product itself?
Product quality and handling are critical. Strict sterile technique for collection, storage, administration. Use proper blood administration sets with filters. Aseptic catheter placement. Minimize any chance for contamination or degradation.
So if a reaction does happen, what's the typical outcome, and are there long-term concerns?
Most reactions are acute. They happen and resolve relatively quickly if managed well. Prognosis is usually good if it's a mild or moderate reaction caught early. It gets more guarded, though, if it's a severe anaphylactic reaction, or if the horse was already critically ill, or if the reaction wasn't spotted and treated fast enough.
And potential lasting problems.
Well, if delayed hemolysis happens, that tells you the horse has made antibodies. Future transfusions will be much riskier and absolutely require cross-matching. Severe reactions can cause secondary organ damage kidneys, taking a hit from hemoglobin breakdown, DIC causing widespread issues, and volume overload, if severe, can potentially lead to heart failure.
So wrapping this up, What does this all mean for you, our listener? We've taken a really deep dive into equine blood and plasma transfusion reactions. We've seen the complex dance between the immune system, other factors like product handling, and why careful management and prevention are just so crucial.
Yeah, it shows how something that seems straightforward, giving blood, actually requires a really deep understanding, from genetics and antibodies all the way to the practicalities of infusion rates and the huge range of signs, from just a slight fever to sudden collapse, really underlines why you have to be constantly vigilant.
You should now have a much better handle on the why and how behind these reactions, the causes, the signs, the prevention, the treatment. It's a good reminder of just how complex biology is and why attention to every detail matters so much in medicine.
It really does. And it leaves us with a thought, doesn't it? We know horses develop those antibodies pretty quickly after even one transfusion. So looking ahead, how might better equine blood typing, maybe even more advanced genetic screening of donors, help us refine donor selection even further to really cut down these risks in the future? Something to chew on until our next deep dive.